good evening, everyone, and good day, because I'm not sure where you are from. So I just want to make sure that you are here and, so of course, are enjoying your day, or you enjoyed your day as it is coming to an end. And I'm very happy to be back with all of you, and also our new special guest, Arie Parnham, is with us tonight. It's good to have you, Arie, here. How are you feeling tonight?
I'm good, thank you very much. Thanks for inviting me.
Thank you so much for joining us and agreeing to be our presenter tonight. It's definitely a pleasure to have you. And let me just mention that Arie, he is the urologist andrologist at the Christie NHS Foundation Trust. So thank you, Arie, for this and presenting this topic tonight, because this is the first time actually we do have this topic, and so I am very interested to find out what you have just simply prepared for us. And as you can see, our topic is varicocele and male infertility. And of course, Arie will explain all the details to you with his presentation. But afterwards, your favorite part will start, Q&A session. So again, don't hesitate if you have anything that you would like to ask. Arie is the person to answer those questions, so don't hesitate, okay? I'm sure he will be happy to help you, and also with his vast knowledge, he will definitely be useful to you. So don't hesitate, really. And as always, just let me mention that my IVF answers, we are part of European Fertility Society, which has been created simply because we want to help out. We want to give you the opportunity to meet top fertility experts, but also we want those experts to help you out with your questions, and that way support you. And as you know, we are here every single day, and this is our next topic on male fertility. And I'm very, very proud to be part of European Fertility Society. That's for sure as well. And well, that will be it from me at this point. So, Arie, are you ready to start with your presentation?
Yeah, let's do it.
All right, let's go ahead.
Great. Well, thank you very much for inviting me, and it's very nice to be able to meet everyone online to do this talk. So the only thing I can't see is the move on. Oh, there we go. Right. Okay. So tonight's talk, I'm Arie Parnham. I'm a consultant urologist and andrologist, and my talk tonight is on varicoceles and male infertility. So what is a varicocele? Well, for many of you will recognize varicose veins in legs that many women will get, and some men as well. And it's very similar in that, but it's opposed to being in legs, it's in the scrotum, and actually it's in the cord, which supplies the blood supply to and from the testis itself, and it's in the veins that take away the blood from the testis. And as you can see from this picture here, on the left-hand side, you can see the left-sided testicle hasn't got dilated veins, but on the right you can see this is what a kind of drawn representation of a varicose veins would be. And why does it happen? Well, the same as in legs, that essentially normal veins have valves that ensure that your blood flow continues in one direction. But in people with varicose veins or varicoceles, those valves that ensure that one-way direction do not operate as they should do. And as a consequence of that, you get pooling of blood. And if you look at this picture on the right, you can see it's a very basic diagram of the layout of the veins from your testes. So you can see, if I just show you my pointer, here we've got a testicle here, and either side you've got on the left a less testicular vein that drains up into the kidney vein, the main kidney vein, which then drains into the main vein in your body. This is called the vena cava, and this goes all the way up to your heart. And the same here on the right-hand side, but the subtle difference between these two, as you'll see, is the vein doesn't go into this kind of side vein, but goes straight into the main vein up to your heart, the IVC, or inferior vena cava. And it's this difference in drainage that actually predisposes your left-hand side to be more common to having varicoceles than your right-hand side, although you can get them, obviously, both sides as well. So what else can we say? So let's move on. So how common are varicose veins? Well, about 1 in 7 men will have, varicoceles. 1 in 7 men will have a varicocele of some form. And around about 1 in 4 men with a varicocele will have some degree of infertility. And if you flip it the other way around, about 40% of infertile men will have a varicocele. So it is something that is associated with infertility. How do you diagnose a varicocele? Well, there are many ways of doing that. Obviously, if you see a doctor about it, they'll take a history from you about what's been going on in your with your kind of sexual history, or what your how long you've been trying for, so on and so forth. And then they will eventually get to a point whereby they examine you, and obviously they'll do a thorough examination. They should look at your testes, and they will look for a varicocele. And there are lots of different ways to look for varicoceles. Sometimes they're very prominent. Sometimes they're a little bit more subtle. And actually, you can grade them to some degree. So, for instance, we would often say that a varicocele can be subclinical. In other words, you have to pick it up with a special test like an ultrasound scan. You can have grade 1, which is you can feel the varicocele, but only during special manoeuvres, and something called a Valsalva maneuver, which is basically where you're trying to increase the pressure in your tummy that then forces that kind of blood down almost, and expands that varicocele in the scrotum. And you can do that quite simply, either by getting someone to hold their breath and then force down or bear down, or blowing against a thumb. And sometimes that can be even made more pronounced by getting someone to stand up. So usually, if I see a patient and I'm going to examine them and see if they've got a varicocele, I will examine them lying down first of all, but I will insist I also get them to stand up as well and blow against their thumb to really kind of see if I can exacerbate that varicocele so I can notice it. Then there's grade 2, and those are the ones that are palpable at rest. So in other words, I don't need to do anything clever. I can just feel it when you're lying down. And then grade 3, which is this picture, as you can see here, this is a visible varicocele. And you don't need to do anything, but you can see it without even touching it. And often when you feel varicoceles, they're often described as a bag of worms. So certainly if you were to have a feel of this picture, as it were, if you could, you would feel it. It would feel like lots of little worms almost within the scrotum itself. And those are just the veins as they kind of wiggle around and curl upon each other. The slight problem with examination, it would be worth saying, is that it's subjective almost. So if you go to one doctor, he may say, well, I can just about feel something. And then you might go to another doctor and who does exactly the same thing and say, well, I'm not convinced there is something there. So it's open a lot to interpretation. But obviously, if it's visible, then it's visible. That's quite easy. But it's the ones with a little bit like grade 1, or maybe even even grade 2, where you get a bit of discrepancy and people struggle. So what can you do to be a little bit more accurate when diagnosing a varicocele? Well, it's quite simple. You could do an ultrasound scan. And here you can see some pictures from an ultrasound scan. And you can measure things. So the good thing about an ultrasound, you can see it, you can measure it using some little markers. These here, you might see them here. These are the little markers. So you can get a size of the veins that are dilated. You can measure the blood flow within the veins, and you can also have a little look at the testicle itself. And there are some criteria, although it's open to a little bit of interpretation. But here, this is what the EAU guidelines classify as a varicocele, which is basically a maximum diameter of more than 3 millimeters in the upright position. So in other words, standing during Valsalva maneuver with some reflux. So in other words, the blood is going the wrong way for more than 2 seconds. And also you correlate that. So you examine someone at the same time. So here you can see this patient here has been measured. You can see the little calipers, and that would be more than 3 millimeters by a good way. And here on this diagram, or this picture here, you can see the blood flow going in different directions, which might suggest some reflux, or when they've valsalvas, or when they've strained against their thumb, or something like that. So a ultrasound scan, you would argue, is a little bit more accurate than examination. So really, anyone who's got a suspicion of a varicocele should really have an ultrasound scan characterizing it. And that ultrasound scan should be done by someone who's used to scanning testes and looking for varicoceles, and would do something similar to what's described in this EAU guideline. So in other words, getting them to stand up, getting you to Valsalva while scanning you at the same time. So that's how you would, or I at least, would diagnose a varicocele. So moving on from there, well, okay, if you have a varicocele, well, does it really matter? Well, we know that varicoceles are associated with certain things. For instance, we know they're associated with male subfertility or problems with fertility in men. Also, we know that varicoceles are associated with people whose testicles, when they've started to grow, so they go through adolescence or puberty, but their testicles have failed to grow appropriately, as it were. So they haven't developed quite as they should do. Varicoceles can cause some pain and discomfort, and often that pain is kind of a dull, dragging, heavy sensation that you can get. And it's often made worse if you kind of, as the same with varicose veins, in the sense if you're kind of standing for long periods of time and towards the end of the day. And it is also associated with low testosterone levels as well. So if we were to think about fertility itself, well, let's look at some of the things we can look at. Let's see if we can link some of these things and see if actually doing something about it will make any difference in terms of infertility. Well, certainly those people men who undergo an infertility investigation will have a semen analysis. And if you've identified to have an abnormal semen analysis, in other words, you've got kind of a low sperm count, otherwise known as oligospermia, then it may be improved by a varicocele. And here is one such study. This was done back in 2013, looking at 49 men who had, in that exact situation, they had low sperm counts and they had a palpable or a clinical varicocele. So if you remember back, that would be either 1, 2, or 3 in that staging. And then they they operated on these patients and they removed their varicocele. So they either did surgery or embolization, and we'll come on to that later on. And they compared their semen analysis before and after. And what they saw after that period of time is that the count, the number of sperm that was seen, moved from 4.8 as an average to 14.3. So that's quite a big difference. And also the sperm motility also improved from 16.7 to 26.6. So actually, by doing a varicocele in this group and repairing a varicocele in this group of men, seemed to improve their sperm counts and their semen analysis. You can also extrapolate this to people who, let's say, okay, you have some people who have low sperm counts, but you also have some people who have no sperm at all. And that can be people who've got non-obstructive azoospermia. So no sperm seen whatsoever, but there's not a blockage. It's more to do with its actual production. And here you can see this is yet another study. And this is basically not one study, but multiple studies all put together. And in total, actually, there were 15 studies reported in this paper. And they basically looked for at men who've got azoospermia with, again, palpable varicocele, so something that they could feel. They then performed surgery on them to correct their varicocele, and then they looked to see if they can find sperm in the ejaculate, whereas previously they didn't have any. And actually, in these, 45% of men, or roughly about 43.9% of men, ended up having actually sperm within the ejaculate at a later date. And that sperm could then be used for IVF or ICSI, and the success rates for that were around about 15%. Which is pretty good, going from no sperm whatsoever to actually having a chance of having a child at the end of the day. So, and if we were to look at another study, this is a very similar one as well in that sense, but looking slightly different. These are the, again, looking at people who've got no sperm when they're in their ejaculate in their semen analysis, but a palpable varicocele again. And in this study, they compared people who'd had a varicocele repair, who had a varicocele repair, versus those that didn't have a varicocele repair. And what they found is if they went to go and look for sperm surgically, in other words, they had surgery on their testes to open them up and have a little look to see if they could actually pick out sperm, the success rate in finding sperm in these patients was better than those who hadn't had a varicocele repair. So you can see it's 60% versus 40%. And again, the live birth rates were better, 75% versus 50%. So again, this goes towards evidence to suggest that actually a varicocele might help in people who've got low sperm counts, and even maybe in those people who have no sperm on ejaculate whatsoever. So is there anything else that we can deduce from data, and what else can we find that might help? Well, the other thing that we noticed is something that's coming in now, which is about looking at DNA damage and maybe IVF and ICSI success. So, okay, previously we did semen analyses and they were okay. They looked at the kind of how many sperm you had, what did those sperm look like, were they good swimmers, etc. But the advent of kind of looking at DNA fragmentation or DNA damage actually gives us a little bit more of a nuanced view actually overall. So this is a study here looking at that exact question. Does DNA damage itself, if you were to look at all those sperm and say, right, if these sperm, have they got good DNA or bad DNA, would it make any difference to your chances of having successful IVF or ICSI? Well, this study looked at 41 patients with patients who had DNA damage or had high DNA fragmentation rates, and then they looked at their chances of IVF and ICSI, and they found that with IVF, those that had high DNA fragmentation had a reduced chance of IVF of 1.92, and those with ICSI less successful at 1.49. So in other words, if you have DNA damage, your chances of IVF or ICSI success are reduced. And that's great, but what's that got to do with varicoceles? Well, let's have a little look at DNA fragmentation in people who have got varicoceles compared to those that don't. And this is another study. Looked at 55 patients with clinical varicoceles. And what they found was that those patients who had a clinical varicocele had a higher DNA fragmentation rate than those who didn't have a varicocele at 5 to 10% versus 35%. Okay, so maybe having a varicocele means that you're more likely to have worse DNA or a higher DNA fragmentation rate. So, knowing that, does it make any difference if we do a varicocele repair in your DNA fragmentation? Well, this study would suggest it does. So this is looking at 37 men who underwent a microsurgical varicocelectomy, which we'll come on to in a second. And they looked at their DNA fragmentation and they found that it went from around about 30%. This is a different way of measuring it, by the way, it's not the kind of standard way, but it's an inferred number. And it actually improved to 25%. So they had reduced DNA fragmentation after their microsurgical varicocelectomy. So you could therefore maybe extrapolate out that and say, well, if you have a varicocele, you've probably got higher DNA fragmentation. By repairing that varicocele, it might reduce your DNA fragmentation, and it may mean that you've got more successful ICSI or IVF. The other thing also that we know is that some people will also have low testosterone rates. And here's a study, and that may be contributing to their infertility. And here's a study, again, this is not one study, but multiple studies, and all the data of these studies have been stuck together almost to try and get the best answer out of them. And it's looking at 8 papers in total. Again, men with varicoceles with low testosterone levels. They underwent a repair of their varicocele, and what they found was that their testosterone rates levels improved on average by 34.3 nanograms per deciliter, which is a reasonably meaningful increase in their testosterone levels. So you could argue, again, if you've got a low testosterone with infertility, this might help with correcting that. So what are your options? Well, really, there are 2 ways or 2 options. One is having surgery if you have a meaningful varicocele, and the other one is having a radiological procedure called an embolization. And essentially, the differences are this. So surgical options essentially involve making a cut in some way or form, using and then using either a camera put into the tummy to kind of find the veins and tie them off, and sometimes using a microscope to identify the dilated veins or the varicocele, and then tying those abnormal veins off. And here the different approaches. You've got a scrotal approach, which is going through the scrotum, the inguinal approach, which means going basically in the groin, open retroperitoneal high ligation, which goes a bit higher, laparoscopic, which is keyhole, and then microsurgical subinguinal. And I'm going to focus just on microsurgical subinguinal because realistically, this is probably your gold standard of surgical option, I would suggest. So this, if you were to look through the data, this has got the best results in terms of surgical option. And this is what it looks like. So essentially what you do is you make a little cut in the groin, which you can see here. You then deliver the cord, which is basically the blood supply, the vas, and some nerves, which supply the testicle. And then using a microscope, as you can see here in this picture, you find the veins and you cut and tie those off, but you leave behind the artery and the vas here. And then you put it all back together again, and that's about it. And the recovery from that, I mean, we'll come on to that later on, actually. So the radiological options are also antegrade sclerotherapy and retrograde sclerotherapy, and the other option is retrograde embolization. And again, I've highlighted the gold standard one. Most people now would perform what's called a retrograde embolization, and what that involves is going to a radiological department. So in other words, somewhere that's able to use X-rays, and they would then put a tiny little access port into your neck in the most common circumstance, and then feed a tiny little wire all the way down the vein into the testicular vein, and then block it off with a tiny little metal coil, which will then cause that vein to then over time to shrink away. And at the end of the procedure, you can see, I mean, you can't see anything. There's nothing to see whatsoever, and it's minimally invasive. So the question, a lot of people go, well, okay, that's great. Which one do I have? And this talk is never, I'll give you a warning now, this talk isn't going to tell you which one it should be, because I don't think there is a right answer, and it kind of depends a little bit upon you. So the first thing to say is, if you were to, what is the one thing that we would like to try and do is get rid of it, obviously, and what we don't want it to do is to come back again. And if we were to compare the rates between the two, so in other words, for a microsurgical subinguinal varicocelectomy, the chances of it coming back are somewhere in the order of 1 to 4%, so pretty low. And with the radiological embolization, the chances of it coming back are around about 3 to 11%, so you would argue a little bit higher. The benefits of the surgery are that the rates of complications are low. It has the lowest recurrence rate, so the lowest chance of it coming back, and it probably has the strongest evidence. In other words, a lot of the studies that we've talked about today are based upon you doing a microsurgical subinguinal varicocelectomy. If you look at the radiological embolization, the benefits of that, however, are that your complication rate is low. You can rapidly return to normal activity. So with surgery, obviously, you usually need a couple of weeks off. Painkillers, you need to look after yourself. Whereas with an embolization, you can pretty much return to work the next day straight away with very little side effects as a consequence of it. With a embolization, you can treat both sides, whereas with surgery, you would often be very cautious about doing both sides in case something went wrong on one side and it was too late already at that stage, where that's not less of an issue with an embolization. You also have a lower risk of damaging the blood vessels to the testicle. In other words, the blood supply that keeps the testicle alive, because you're kind of going down the vein and you can't really affect the artery. Whereas with surgery, although uncommon, you can damage the artery and the blood supply. You can repeat after an embolization as well, and it's also fairly readily available. But all these are kind of things to consider, but not givens. The disadvantages are here. So, for instance, surgery has a longer recovery, not easily repeatable, I would suggest, because often it becomes very scarred, and it requires specialist surgical skills, so microsurgical training and experience in it, because it's not an easy operation, and not an easy operation to get right either. And it needs specialist microsurgical training, as we talked about. Whereas with embolization, the disadvantages of it uses radiation, although the radiation levels are quite low, are very low. its recurrence rates are higher, so in other words, failure. The little metal coil that you put in can move, although that's very uncommon. And you can get some discomfort from the coil, but you could argue also you can get discomfort from the surgery. Because you've put a little metal coil in, if you have further imaging in the future, for one reason or another, you can find that shows up on the imaging and sometimes distorts images. And you also have to put a dye in, and some people are allergic to that dye, although again, very, very uncommon. So in summary, my view of this is, does it make any difference which one you choose? I don't think it does. There are studies out there that are being designed to look at that difference to see which one's better, but they're not here yet and they don't have those answers. So at the moment, I offer both of these if I'm going to talk to someone about a varicocele and getting rid of it. So in summary, and this is taken from the EAU guidelines, for varicoceles, you should not treat do not treat varicoceles in infertile men who have normal semen analysis and in men with subclinical varicoceles. So in other words, if it's just picked up on an ultrasound and not in any other way, you shouldn't be treating people with that. You should treat infertile men with a clinical varicocele. You should treat men with a clinical varicocele, abnormal semen parameters, and otherwise unexplained infertility in a couple where the female partner has good ovarian reserve to improve fertility rates. And varicocelectomy may be considered in men with raised DNA fragmentation with otherwise unexplained infertility or have suffered from failed or assisted reproductive techniques, including recurrent pregnancy loss, failure of embryogenesis, and implantation. And you can, although they're not in the guidelines, I guess, consider varicocele repair in men with clinical varicoceles and non-obstructive azoospermia. And that is the end of the talk. So,
wonderful. Thank you so much, Arie. It's been a great presentation. Lots of details. And as I mentioned, this is our first topic actually on varicocele. So thank you so much for bringing this as well. And as you can see, there is one question ready, but someone is typing, and I believe that we will have more questions. But of course, once again, if you would like to ask anything, this is your time to do it. Arie is here for you. So go ahead, type those in. And let's have a look, okay? The very first question we got from Robert right here. So let's have a look. I have had 3 semen analysis in last 6 months. Lower motility in first test, 22% DNA fragmentation. Higher motility, second test, and higher DNA fragmentation, 28%. Lower motility, third test, DNA fragmentation down to 23%. Was just diagnosed with varicocele. Is flip-flop motility DNA unusual?
and the answer to that is no. I don't think it is, actually. So if you look at your semen analysis from one semen analysis to another can vary quite significantly, and it depends on so many other different factors. So for instance, if you have an illness over a period of time in between those or just before a semen analysis, you can find that has a significant change in your fertility. So you might find that your sperm count goes down, your motility goes down, it might change your DNA fragmentation. And if you look at DNA fragmentation while you get it, that's still something that's really been worked on, but it's looking at things like these environmental factors. So for instance, heat, which is part of varicoceles, contribute to kind of increasing the temporal or poor temperature regulation of the testicles. So it's not abnormal. And I think one of the things that when we do semen analysis, we just don't do just one, we actually do several, because actually then we get a bit of an idea and a trend of what is going on with your fertility. I hope that kind of answers your question.
Thank you so much for the first question, and indeed for your answer and advice here as well. Yeah, thank you so much. Let's have a look, okay? There is another question. I have 4 millimeters varicocele on my left testes, but also have 99% MAR antibodies, which should be at least 40%. Would removing the varicocele make any difference to this?
I'm not sure if it necessarily would. I think if you look at what you've described there, I'd suggest that actually you've got a varicocele, you've got your MAR antibodies. I couldn't definitively say that it would make a difference to that level. I don't think I could say that, but I think if you've got infertility and that's been ongoing, then repairing your varicocele would likely improve your chances going forwards.
And thank you once again for yet another question and your answer to that. And right now, I do not see more questions. However, I was able to see that someone was typing. So let's give it a second. Of course, don't hesitate. I mean, we are here to for you. So if you have any questions, you know what to do, of course. And let's have a minute. Okay, we just need to wait a bit for the question. Okay, let's have a look. Okay, we have another short one. Can varicocele go away on its own?
Not usually, I would suggest. I mean, the fact is that usually the veins themselves aren't working properly, and as a consequence of that, they don't usually repair themselves. So most of the times they don't. You can do certain things to help kind of mitigate against your varicocele. So, for instance, some people find that kind of wearing kind of snug underwear can sometimes help, but then that equally does the opposite effect of kind of really kind of heating up your testicles, which you don't really want. So it kind of depends on what your problem with your varicocele is. If it's fertility related, then the answer usually is you probably need it correcting.
Okay, again, thank you so much for that question indeed. And James has added one more question for you. So, can you get this minor surgery on the NHS or have to go private?
You can get it on the NHS. So yeah, you can get it on the NHS. I think you have to find certain centres that will do it. So if you're referred to your local fertility unit on the NHS, then they should be able to offer you at least one of those options that we've discussed today, whether that be embolization or microsurgical varicocelectomy. So the answer is yes, you can.
And again, thank you so much. It's good to know that as well, for sure. Okay, more questions are coming in. I see some people typing. So, are varicoceles very common in men?
Well, as I said right at the beginning, kind of in men overall, varicoceles around about 1 in 7 in men. So they are relatively common, and certainly they're more common in people who've got infertility as well.
Okay, thank you for the clarification to this one as well. Okay, let's see. Next question. Are varicoceles more common in older men?
Ooh, you know what? I think they probably are over time, and just as varicoceles in women are more common as you get older, varicoceles will be the same. You would imagine they would be more common in older men as well.
Okay, thank you. Let's have a look. Again, we have another question, a bit of a longer one. I have received conflicting advice on whether it is safe to try to conceive naturally with DNA fragmentation above 15%. One fertility specialist says higher risk of miscarriage. Others say evidence is not that convincing. If the DNA fragmentation is borderline, 22%, don't worry. Any advice? Wait for surgery and hopefully reduce DNA fragmentation, or keep trying and go for procedure?
Okay, so this is often, I mean, DNA fragmentation, I think the first thing to say at the beginning is kind of an evolving area within male infertility. And so I think why you're getting this kind of variation in advice is probably because it is evolving, and I don't think there's any definitive answers fully in this. So we know that if you've got a higher DNA fragmentation rate, your chances, you're the specialist here, your chances of having successful IVF or ICSI is lower. So that would be one reason why you may find that that doesn't work. And again, but these studies are small studies. So they're not like massive, massive big studies with hundreds and hundreds of patients or thousands of patients. And so you can't definitively say that. And there aren't, as far as I'm aware, large randomized trials looking at it. So I guess it depends on what you've got. If you've got a varicocele and you're having issues with conceiving naturally, then I guess one of the things you might want to consider is a varicocele repair, but will it make a massive difference? No one could promise you that, if that makes sense.
Hi, Arie. I hope you can hear me now.
Oh, yeah.
Okay, sorry. Yeah, so thank you so much. And this is the question. Do you know how I can reduce my MAR antibodies?
Oh, that's a difficult one. I mean, the short answer is not really. There's not any convincing, obvious way to kind of reduce your antibodies. A lot of people will say kind of dietary supplements and things like that, but there's no convincing way that I'm aware of.
Understood. Thank you so much, of course, for that. And at least for now, it might be our final question. But if you have anything else that you would like to ask, this will be like the final call. So go ahead, do it now. And the question is, so if we had successful surgery removing varicoceles, is it possible that they will happen again?
They can. And that comes back to, it depends on what you choose. You've chosen surgery here. If you choose surgery, that's probably your best chance of it not coming back again, based on the data that's available, and that's somewhere between 0 and 4% of it coming back. So yes, they can. That's the case with any surgery, and nothing's ever 100%. But that's probably your most reliable way, I would suggest. But I mean, equally, embolization, the recurrence rates in embolization are somewhere between 4 and 11%. So they're not vastly different.
And amazing. Thank you so much for yet another answer, of course. And as I mentioned, it might be our final question. And as I do not see any more questions, we will be finishing. But of course, before we finish, Ari, anything else you would like to add to our session tonight, to our audience?
Nope. I just hope everyone out there who goes through kind of male infertility and has these issues, kind of want to make people realize that people are out there to kind of help you with these issues, and it's not. Hopefully, you don't feel alone with it. I think it's important that these things are publicized and people know about it, and they don't feel alone. So I'm glad people really kind of encouraged to see that people are here, kind of wanting to find out some answers.
Definitely. I am very happy to be a part of it as well. Definitely. It's wonderful to see that all of you are coming in here asking your questions and just finding out that there are ways to treat things, there are ways to deal with it. And that I think it's the most important part, that you are not on your own. Yeah, because as you can see, there are many people out there that are having similar problems as well. Okay, so I guess this is always it helps, that knowing as well. Thank you so much, everyone. And Ari, you've been brilliant. Thank you so much. A wonderful presentation for sure. And as you can see, there are some thank yous right here for you from our
Pleasure. Thank you very
audience, our
much.
patients. So huge thanks for that. And I also want to add that this has been recorded, so you will have a chance to watch this again on my IVF Answers. It will be available tomorrow. But if you subscribe to our YouTube channel, you will be notified that the video is uploaded. So I can only encourage you to do that. And if you go to our Facebook or Instagram pages, then you will see that more events are coming up. Tomorrow we are back with yet another and final event on male fertility. So I do hope to see you there at 8 p.m. We will be back. And Ari, once again, huge thank you so much. And I just hope we will have a chance to have another webinar with you. And I'm sure there are many, many topics that you would love to discuss. So yeah, till our next time then, I hope.
Lovely. Thank you very much.
Thank you. Have a lovely evening, everyone. Bye.